I'm Denise Cumming. I'm the Executive Director of University Hospitals Kingston Foundation, and it is always a pleasure to look around this room and see so many familiar, warm and supportive faces. So I'm so glad to have all of you here. I do want to take this opportunity to thank you for your very faithful support of the foundation and of the hospitals that we support. I think all of you know that University Hospitals Kingston Foundation is the fundraising arm for Hotel Dieu Hospital, Kingston General Hospital, and Providence Care. And I imagine all of you are familiar with the fact that we launched the Extraordinary People Innovative Healthcare campaign. If not, let me know. We'll do a little more marketing. I am thrilled to announce that at this point in our campaign, we have achieved 62% of the $65 million goal. And you may recall we were just at 50% when we launched in September, so this is just a remarkable testimony to the generosity of this community and our common desire to see exceptional health care and exceptional people delivering that care in our community. I think all of you will be aware that Bell Canada is our very generous sponsor of these luncheons, which are held 3 times a year. And I wanted to acknowledge that Jason McDonald is here with us today. Jason, representing Bell. Thank you for your ongoing support. It's great to have you here with us. These events are intended to connect all of you with things going on in the hospitals so that you have the opportunity to identify areas of particular interest to you, be ambassadors for us out in the community when you tell people about the amazing things you're going to hear here today, and consider whether you might wish to direct gifts to one of the areas where you see care being highlighted during our presentations today.
Great being here, and it was a great meal. Thanks so much. I wanted to talk to you about the Urgent Care Center at Hotel Dieu. First of all, I thought I'd show you these pictures way back. Hotel Dieu opened in 1845 as the first public hospital in Kingston, which is hard to believe. Over the years, it's changed from an inpatient hospital to an ambulatory care center. We changed from having an emergency department, which was that first picture, to an urgent care hospital. The city of Kingston and Hotel Dieu have changed quite a bit with the addition of a lot of buildings and services. At Hotel Dieu, we built Centenary, Brock, Johnson, and G-Man's wing. Some of the major changes also have been the bariatric center, the pain clinic, and the Mohs micrographic surgery clinic, which is a mouthful, but that just opened this summer. We continue to change, and our biggest goal is to provide the right care at the right place, align our services, and not to duplicate what our partners are doing very well, and to give the best care we can, to increase the range of care we give with different models of care, to participate with the family physicians in the community and work with them so that we can do better care for people, so even preventing people from even coming to both hospitals if we can. So I wanted to show you this. This is in 1956, the emergency department in Kingston at Hotel Dieu saw 14,000 people. At that time, when I looked into the stats, we had a population of 50,000. So pretty interesting. In the late 90s, the ministry came along and said the city of Kingston should have one emerge department, and we have a really great trauma center at Kingston, at the Kingston General Hospital, and we became an urgent care center in about 1997. And as you can see, our numbers kind of did a drip there once, and we're right back up right now to about 49 to 50,000 people a year that we're seeing through the Urgent Care Center. Urgent care, one of the latest changes we did was the Urgent Care Center thought we could do better. The time it took for people to wait to get in to see a doctor and the whole length of stay were slightly increasing. They were still within the province's targets, but they were starting to increase a bit. So our staff felt that we could do a better job. So we had an independent review come in and take a look at urgent care centers across the province and say, what can we do? Because we had been in emerge before. What can we do as an urgent care that can make us better and serve our patients better? So they came in and did that. Our goal was to have people in and out for a minor thing in 4 hours, and that's from the time you got to the door to the time you were leaving. And if it was a more complex thing, 6 hours. And that was our goal, and that's what we looked at. And we had an independent review done in June 2013. So they compared us against the 4 major urgent care centers in the province, which are Hamilton, Toronto, and St. Joseph. And we're probably most like St. Joseph's in London. So with the results of that, we called our partners at KGH. The physicians work at both places, and I think people know that. So the physicians were there, community family physicians were invited, CCAC, and a bunch of people, and we showed them the results of this independent review and thought, help us, what can we do to make things better? We also invited the LIN, of course, which is the ministry there, and they developed a two-phase plan to see if we can do a better job. The first phase looked at, our hours were long, people were coming early in the day, and then throughout the day, they were dropping the amount of time that they arrived. So they changed the hours to 8, they changed from 8 to 8. So we aligned our staff, because we couldn't get more staff, but what we did was made sure the staff were working at the same time that the patients were arriving. Before, what happened is we had everybody staggered throughout the day. So now we are aligning the staff hours with the patients. And when we did that, losing those couple hours in the evening also allowed us to give radiology, so x-ray and services on the weekends, and which we didn't always have before. So we were able to provide services that we did by changing the hours. We also, the radiology department also by doing this was able to give some spots in the day for people that were seen in the Emerge and at UCC to come back the next day and have next day our CAT scans so they could be seen and treated by the physicians and discharged. Instead of what was happening before in our busy Emerge department was people were going back there waiting to be seen, waiting and then having an x-ray or a CT scan and then being seen by the physician and discharged. So being able to arrange spots where you could come to Hotel Do the next day where it was safe to do that, we had them come back the next day. And so they weren't going to the Emerge department. So once we changed our times, you can see the first slide is how long it took somebody to get through the emergency department before we did the change. And this is in minutes. The second slide is during the change, and the last slide is the last 3 months. So the length of time it's taken for somebody to show up at the urgent care, be seen and discharged has steadily decreased. So even though we've changed our hours to shorter, we changed our staffing, we put more resources at the time when patients were arrived, so we weren't getting behind track all the time. This just shows you, just briefly, when people were arriving. You can see the green is basically now. People arrive early in the day, and that's when the majority of people come, and they start cutting off and not coming as much after 5 o'clock in the evening. So we aligned our staff so we had overlap during that time when they came. Instead of only having one physician or fewer nurses, more people were working at the busy time so to get people in and out instead of being behind as the day went by. The phase 2 of this independent review was how could we brand ourselves and make sure that people knew that we were an urgent care center, not an Emerge, and we could do the things that we do what we do the best and make sure that people came. So we went to St. Joseph's in London, a small group, which was a couple of frontline nurses and some other staff to see how did they do it. Because St. Joseph was like us. They changed overnight from an emergency department to an urgent care department. They were open 12 hours. So we took a little things and said, what could we do that would make us better and more efficient? So some things were just how one person would do one thing one way and another would do another. So we streamlined it and made it so that everybody knew exactly what we're doing. We had a little group that included some patient advisors. We had some frontline staff, some ward clerks, some secretaries, and we took a look at that. And we decided on some of the small things that they thought would make things better for us. And those little things all added up by just listening to our patients and listening to the frontline staff. So those added up to making improvements in the length of stay. One of the other things we did is we introduced registered practical nurses into the urgent care center, so they're RPNs. We looked at all the other urgent care centers in the province. They all used them for the patients that were considered less acute, so they didn't need extensive testing and extensive medical things. So at one time now we have 1 to 2 RPNs working along with all our RNs, and that's in an area we call the fast track. So people that maybe just have a sprain or a sore throat, they can get in and go. They don't need a bed. So that's made an improvement as well. During phase 2, we also went out and surveyed our patients. So we made a survey and asked them, why do you come to us? What are you looking for us? What are the reasons? Do you have a family physician? So we got a lot of information from people. knowing that some of the interesting things we found out were most people did have a family physician that we were seeing. Most, it was convenience from where they came. A lot had to do with being on a bus route and daycare and stuff like that. So I think the more we understood about who is coming, the better we are to help them. Soon after that, St. Lawrence approached us. We have a nursing student who I've invited today here, Serena, is with me if she can wait. They wanted to do a research into urgent care. So everything out there has been in emergency care. So we wanted to look at urgent care. She did a research project as well, asking patients, what do you want from an urgent care? And she did a great job, and she's getting published right now and nationally for that work. And so I've invited her, if you have any questions for her, it would be great for her to answer. Recently, too, over Christmas is a very busy time for both emerge and urgent care. And our partners at PGH developed a survey asking patients, why do you come and what services do you need during the holidays and how can we help you? So both of us administered that over the Christmas holidays so we can figure out what can we do to make sure that people don't have to wait at Christmas, because often if you've been to the emerge or the urgent care at Christmas, it's a very long wait. So that was one of the things we did. One of the things Hotel Dieu did at that time was open up the COPC Children's Outpatient Clinic during the week of Christmas, and that offloaded people coming to urgent care and emerge so that the other people could go through and faster in those two places, and the children were seen by pediatricians. Another thing we've worked with is working with Health Links, and Health Links is a project out in the community with family physicians, and it's trying to find people who maybe don't have a primary care physician, who have multiple problems, health problems, and trying to get a primary resource for them. So often it's a nurse, sometimes it's an OT that helps them develop a plan, helps them somebody that they can keep contact with and help them arrange all their different appointments, make a plan, so that when they go to the hospital, they can prevent some visits and get to a specialist faster, get connections with mental health, stuff like that. So this is a community project through family care. Health Links has been going on in the province now for about 3 years. Kingston has a Health Links clinic, and we've been working with them quite a bit. And so Kingston has seen a 21% reduction in emergency visits by people who have complex problems, having one person that they can call and be a contact and help them navigate how to get to a specialist and plan. So that's reduced emerge visits by 21%, 28% in urgent care. And when these people get into hospital and have to be admitted, their lengths of stays are shorter because they've had somebody that's worked with them and maximized their health. And that's really through the community, but we've been really trying to work with them to support them through this. So this is just a graph to show you the first time. The first one, the dark blue, is after these 84 patients were signed up from Health Links, the number of visits they had to the hospital, and then the second one too. So it's made a difference for these people. So if they can get preventative care, then they don't end up in the emerge and the urgent care, and then other people are in. Our vision and what we want to do is keep improving, and we want to make sure we do what we do well. We want to be an urgent care center, support our partners at the emerge department, but we're an urgent care center. One of the big things we want to do right now is look at the building design. The building has been there since the early 80s when it was an emerge department, and it was built as an emerge department. So one of the things we're looking at is the triage. If anybody's been there, it's one little desk area with one nurse that faces this way and the waiting room's this way. So one of the things we want to do is open that up so that the nurse can actually see each other, and so there's room for 2 nurses to come in when that big influx at 8 o'clock when that lineup's there. So 2 nurses can work through and get the people going through. We want to develop that fast track, which is an area where people who have less serious problems can go and be seen that don't need a bed. So people aren't waiting for a spot to be seen when they don't need a bed. Maybe it's just a little bit more private area where there's a chair or something like that. So those are our biggest things right now. This is just a picture of the volumes that we see, and if you can see, the purple is what's considered less urgent, so that may be something like a sore throat and sprain, and that's what we're seeing the majority of. And so we want to make sure that we can do that well instead of making all kinds of beds, and we still will do that, but we want to be able to treat those people and keep them through. There's my triage right now, and this is facing that way. Out this way is the waiting room where all the patients are. And this is what it looks like. I thought I'd show you this staff. This is the front desk. It's got a little bit of a paint job, but it's basically the same thing, and I think that was supposed to be 1976. So we've been very lucky with a lot of community support, and we still like our area, but I mean, there's always room for improvement, and we always want to hear from our patients and everybody else to see how we can improve. So once again, thank you for all your help.
I love talking about the emergency department, so this is fun for me to promote the good work that everybody does. You'll see from some of my pictures as well, the space that we're working in is less than ideal, but we do the best we can with what we have. So I'll share with you some of the work that we've been doing. So just as a starting point, PGH was founded in 1838, and it is Canada's oldest public hospital. Sorry, Carol. We are the tertiary care centre for southeastern Ontario. Our focus is really on complex and specialty care. We're home to the Cancer Centre of southeastern Ontario, and we are a teaching hospital with ties to Queen's University. So our activity has been about 56,000 visits per year, but this year we're trending closer towards probably about 60,000 we'll hit by the end of this year. Many of our visits are the higher acuity, so the sicker patients are coming to KGH because, as Carol said, they see a lot of the lower acuity patients. So the department is quite busy with very sick people. We typically see about 155 visits per day, but that can range anywhere from 140 to 180, and we've seen upwards to 200 people on really busy days. So it is a busy place. And again, on average, about 30 people get admitted to the hospital through the emergency department every day. So the layout of our hospital, as I said, it's an old space. So as we grow, we try to move into different areas. So we've got 5 sections within the department. Section A, which is right at the front as you come in through the ambulance doors, is our acute area. Section B is more or less a hallway, and it's where we do our fast track. Section C is an older part of the department, and we use that mostly for patients who have been admitted and are waiting for a bed upstairs, or patients that are consulted to a service and not for the emergency physician. Section D is a subacute area. We actually have 12 rooms. 11 of them have stretchers and 8 of them have chairs, and I'll explain a little bit about why we do it that way. And then Section E is another area that's got 3 single large rooms, and that's for our mental health population. So here's a diagram of the department, just so you can see. It's hard to tell on paper, but it's very disjointed, I guess, for lack of a better word. But each section is very separate from each other by walls. It's hard to flow, so you can see, starting here. Get anywhere in the department, you're going through various hallways, so nothing is interconnected. It's not really efficient for the staff because they can't see what's going on in other areas of the hospital, so people are really isolated in their areas that they're working in. So we knew we had to do some improvements with the physical plant that we were living in. So back in September 2013, the emergency team decided that we need to improve our performance. We belong to a provincial initiative which is called Pay for Results. And Pay for Results measures different indicators. It divides it up between wait times and length of stay for patients who are both admitted and not admitted. And we get ranked against every other hospital in the LHIN, regardless of the size of the hospital. So there's 74 hospitals, sorry, not in the LHIN, in the province. There's 74 hospitals in the province, so we're being measured against all of those hospitals, regardless of size. So when the rankings first started to come out, we were amongst the lowest. So places like London, Hamilton, Sunnybrook, if you think of these big centers, they were actually doing worse than us. But places like St. Mike's and Thunder Bay, these are our peer centers, they were doing better than us. So we were looking to them to see how we can improve. So I'll get into our wait times and what our targets were and why we went down this path. So we went with a lean approach, and we started to look at the patient journey. So we wanted to understand what it looked like through a patient's eyes from the minute they arrived at our triage desk till they were discharged from from emerge, so whether that was admitted or they went home. So we did a value stream map, and we did it through the patient's eyes, but we also had patients that were part of this exercise, so we could really understand. This is really hard to see, but it's a picture of what we came up with. So the top one was just our very rough value stream map, where we started to look at the process from arrival at triage and every step that the patient took along the way. The one on the bottom is actually a bigger exercise that we did corporately. We had, I think it was over 50 or 60 people in the room that looked at that second value stream map, just so that we could see where there was value add and where we had opportunity for improvement. So what we learned was that a significant part of the patient's journey was spent waiting. We don't consider waiting to be a value add in most cases. So patients who did not end up being admitted had about 41% of their time was value added during their total stay. For patients who were admitted, only 17% of their visit in the emergency department was deemed to be value added. So you can start to see there was a lot of downtime, a lot of waiting. So we are starting to look for ways on how we could improve on that waiting and have more value added time. So some of the things we started to look at was front loading, the diagnostics, and decision making. We wanted to optimize our space by eliminating unnecessary stretcher time. So not everybody that comes into the emergency department needs to wait on a stretcher. We wanted to move away from sequential thinking so that we weren't waiting for one thing to finish before we started something else, and there was many things that we could do in parallel. And we needed to standardize a lot of these processes. The other thing we did, much like Hotel Do, was we optimized the alignment of our resources to the demand. So we aligned physician and staff schedules to when patients were arriving. Another initiative we started was our RAS unit, and that's Rapid Assessment Zone. And really what this is more of a principle that fosters the early assessment, the initiation of diagnostics, and the optimization of stretcher use. So it took all of those improvements that we thought could help our wait times and pulled them all together. So for example, patients who can, as I said, if they can wait in a chair, we're moving people from stretchers into chairs to be able to wait. So when I spoke about section D that has 12 stretcher spaces, we actually removed one of the stretchers and put chairs into that room so that we could optimize the space. That then frees up a stretcher so that somebody who's in our waiting room can get into the back faster to be seen. Along with that, we initiated medical directives at triage. So what this allows is for patients who meet criteria, the triage nurse can actually facilitate getting blood work, diagnostic imaging, so x-rays, before the physician actually sees the patient. So by the time that the patient arrives in the back and the physician goes to see them, some of those results are already back. So that really minimizes the waiting time. And in order to make that successful, we introduced a phlebotomy and ECG team in the emergency department. So we've actually designated a room out in our waiting room where patients can be brought into that room and have these tests started even before they get to the back. Another initiative that we did was we needed the staff's engagement. We know that the frontline staff know every day where the delays are, what can be improved. So we needed to hear from them. So we got into the routine of having these daily team huddles, and we called it our paper results dashboard or huddle board. And it really was an opportunity for us to look at our day before results. So we've got a wonderful system in our emergency department called EDIS. It's the Emergency Department Information System, and it gives us real-time data. So every day we can pull off our results from the day before. So that enables us to have a real-time conversation about what happened in the last 24 hours. So this is what our board originally looked like. It was just a whiteboard, it was very simple, it had our metrics up there. So what we're measuring is our PIA times, which is our physician initial assessment. So the target is that every patient is seen by a physician within 2 hours of arrival. For patients who have a minor length of stay or minor acuity, we expect to have them in and out of our department in 4 hours. And if it's a more complex condition, we want them in and out in 6 hours. Now what's missing from our dashboard here is the length of stay for admitted patients. And we did that very purposefully because when we went out to talk to the emerge staff, all we heard from them was, if you get the admitted patients out, we don't have a problem, we can do this. But we weren't focusing on the things that we could change. So that was really what our conversation needed to be every single day, is what is in our realm of control and what can we change? So we focused very purposefully on these people who were going home from the emerge department. This is what our dashboard looks like today. It's a bit more sophisticated. And so what we started to do was to trend. So we went with a simple green, yellow, red light system. We have our measurements here, and we did it on percent. So we were looking at the percentage of patients that met each of these targets. But we took it a step further. And it's really hard to see, but on the numbers there, we actually talked in patient numbers. So we said if 9 out of 10 patients, this is real numbers, if 9 out of 10 patients got through in 2 hours, 4 hours, or 6 hours, what happened to that one other patient? So talk to us about where there was a delay yesterday that we can start to look at to fix. So the staff are great at coming up with examples of, well, I sent a patient over to x-ray yesterday and it took 3 hours for them to call the results back. So we invited diagnostic imaging to come to our huddle board so they could hear that these, and we started to share patient ID numbers so they could actually trace back on a single patient. So it didn't become this happens all the time, it became this happened to this patient yesterday. And that created some improvements in diagnostic imaging. It created some improvements down in the lab because they were hearing that turnaround times were slow on certain tests. So a lot of people started to get engaged in this conversation. And what was really neat about it was at a individual patient level that we were talking. So we didn't talk about percents. We talked about 150 out of 160 patients got through, 10 didn't. Tell me about those 10. And the staff are really, really good at telling us what those delays were. And we continue to hear about them. So I went around to take some pictures. So I don't know if everybody's had a chance to be in the emerge department, but this is what it currently looks like. So the top picture here is what we call section A. So this is where the ambulance come into the department. The picture down in the corner is also in section A, and it's what we call our offload stretchers. So we've dedicated 4 spaces so that when the ambulance comes in, there's a space for them to offload the patient, so then the ambulance can turn around and get back out onto the bed. So it prevents offload delays. And it's always exciting to say we're probably one of the, well, I know we are, the best hospital in the province as far as offload time. So our offload times are about 8 minutes, which is unheard of in any other hospital, which is great for the community because it means those ambulances are getting out of the department and back on the road. The picture down here is what I called section C. So this is where patients who have been admitted waiting for a bed wait. It's not a nice space to wait. There's no windows. It's low ceilings. We've done what we can with some nice bright lights. You can see the curtains. Those blue curtains are actually recyclable curtains. It does brighten it up a little bit, but it's still not a nice place. You can see the old millwork. It's probably the same era as Carol was talking about. And then up in the corner here is the hallway that we call section B. So you can see from the pictures that the date of the department, and it can use some upgrading for sure. So this is what we would envision as our nice, new, bright looking space with the individual rooms, private rooms, a standardized room, which we currently don't have, and I talked a little bit about that. Right now people wait for different areas depending on what they present with. It would be nice to say next available space is suitable for any patient. So standardizing patient rooms is one of the things we're looking at. And then this is just a photo of the chairs, the recliner chairs that we can move people off of stretchers into chairs. We don't currently have an ambulance bay, so when ambulances pull up to the doors, they can almost back all the way up, but not quite, because there's an overhang and the ambulance doesn't fit. So there is a period of time when patients are being offloaded that they're outside before they can get into the building. Part of our thinking is it would be nice to have an ambulance bay where the ambulance could actually drive through and it's warm and people can get inside.
The comments and the talks that Carol and Julie have given, I think have given us a pretty good idea of what we're up to in both the emergency departments. I still accidentally call Hotel Dirt Emergency Department because I remember when it was a full-time emergency department. And so what I'm going to do is just sort of personalize a little bit about what we do in our jobs in emergency medicine, and what some of the challenges that we face, and the types of patients and situations that we have to deal with. I will say that I have had the benefit of being out there working for quite a long time now, and some of the advances that have happened in terms of treatment and therapy, and just diagnosis and things like that are amazing, considering what it was before. And just look at things like cardiac catheterization and things like that we did not have 25 years ago, and the changes have been quite remarkable. This is I'm going to primarily talk a little bit about what happens at KGH, but it's pretty applicable to almost all of our types of situations. One of the things, does anybody remember, this was last week. One of the things that I think we have to understand is that in the emergency department, we actually can go from 0 to 60 in a very, very short period of time. We can actually be, sitting around, have everything under control, and then actually have a blizzard like this, where we have multiple people with heart attacks, fractures, falls, snowblower injuries from the hand and getting into the snowblower, etc. And I think this personifies what we have to do in our jobs. And I think one of the things that many of our patients sometimes don't understand is that, why is it that all of a sudden the waiting room appears to be empty and now I have to wait a long time? And sometimes they don't realize that we've actually had 40 patients from a bus accident on the 401, which happened last year around Christmas time. We were at full capacity in our emergency department and really had to sort of open up a gymnasium to look after patients and things like that. So there are some challenges there that we actually have to sort of face up to in terms of the nature of the practice that we do. And I do think one of the things that we've done a pretty good job with is trying to be flexible. And since Karen and I have taken over our roles, I think our goal is, I think, to make our emergency department urgent care center a top-notch center. I think we actually have the tools to do it. We've got lots of people to help us. We've got a great facility and great staff and great teams. And I think with a little bit of tweaking and things like that, I think we can really make it very special. This is just a sort of another example of what happens in the winter, where we're inundated with trauma and fractures and things like that. Plus, they're kind of cute, I think. Anyway, just to give you an example of some of the things that happen, particularly at KGH, is we actually have some pretty specialized services. We have a stroke team. This is an example of somebody having a stroke, where our patients in the region are diverted to our hospital and can receive clot-dissolving medication within a certain window, and can convert somebody who could be paralyzed on one side to totally back to normal within a few hours. And I don't know if anybody's had that experience in the room. Anybody here had any family members who've actually benefited from that? Yes, I mean, it's actually miraculous and amazing. And when you think about years ago, before we had that technology, our people who had had a stroke would be left with major permanent neurological disability. Our cardiac catheterization program, has anybody here known or had to have cardiac catheterization? you know, it's remarkable. And one of our assistants, her husband, called and said, I'm having chest pain. And he came in by EMS, and the whole system was routed such that he was actually on the table having a cardiac catheterization 13 minutes after he arrived in the emergency department, which I think is amazing, and saved his life and opened up his blood vessels. And we have multiple other programs like this that are advanced. Our sexual assault family violence team is available 20 hours a day. Our trauma team, we have a very good trauma team that operates. We see probably 200 to 300 major traumas per year. And these are major injuries with, you know, people who are unconscious, on life support, that sort of thing. So we actually can mobilize these teams in a matter of seconds. I think it's also important to remember that it's not just the doctors that work there. It's a team, and you know, at Kingston General Hospital, we actually have probably about 15 nurses there at any given time. We have social workers, we have respiratory therapists, our lab people, we interface with the police, the paramedics, and it's a huge family of people that work. And our housekeeping staff do an amazing job. We have to move people in and out to transfer patients. And on some of our days, one of our challenges has been that we have been burdened with a lot of inpatients in the emergency department. So sometimes, despite the best efforts of the hospital, we may have 20 or 30 plus of our 40 beds with patients that are meant to be inpatients in the hospital. And we're actually making major steps to make that better. And I think that we have, I think, made a huge change in the last year, and it will continue to get better. But sometimes in the past, it had been quite challenging to see our 170 patients per day with 4 stretchers and, you know, hallway space and that sort of thing. So I think that's one of the moves that has helped quite a bit. I think we're working on that. We see patients of all ages, from newborns all the way up to people well in their hundreds. And many of our patients are getting older, and that's one of our challenges, is to provide great care for everybody of all ages. And you know, most of our younger children are in with fractures and minor problems and fevers and that sort of thing, but sometimes they do have serious issues. And the nice thing about Kingston General Hospital and you know, our region is, I think, we have very specialized care for a relatively small community. And I think that is one thing that sometimes I think we fail to realize, is that you can have your child in a specialized neonatal intensive care unit, and they don't have to be transferred elsewhere most of the time and that sort of thing. So we actually have really good specialist backup in the hospital to look after all the people of all of our ages. One of the challenges is we do have a significant number of mental health emergencies that come into the emergency department, and we actually are well equipped with our inpatient psychiatry unit, our mental health social workers, our psychiatry team to help deal with these. And this slide is also highlights some of our vulnerable patients that actually have to come to the emergency department, because we are basically the safety net in terms of the vulnerable people in our society: homeless, intravenous drug users, you know, people who've suffered poverty and that sort of thing. And we are kind of the safety net, and many of our patients come in for help, and we do our best to help them under the circumstances. We have a significantly large population of intravenous drug users in Kingston, which sometimes I think people don't realize that actually have really significant healthcare needs. And we have the prisons nearby who actually, many of we look after their prison population, and they have some very specialized and difficult advanced medical problems. We also have to do lots of procedures. This is actually one of our most common fun procedures, removing fish hooks. If anybody would like some hints on how to remove a fish hook at the cottage, at the end, both Karen and Louise and I have some very special techniques that we could give you that save you having to come to the emergency department. But one of the things that we actually do is a lot of different procedures in both urgent care and KGH. And you know, ranging from suturing to draining of abscesses to chest tubes to, you know, a variety of different procedures. And you just have to watch ER to actually sort of get an idea of some of the stuff we do. And in fact, that show is actually not that unrealistic. And I don't know how they quite get all their 20 trauma patients into the operating room simultaneously. We are still challenged with that. One of the questions that we have is Dr. O'Brien, why did I have to wait for 4 hours to be seen? And the difficulty is that sometimes we may have been challenged with space or a serious case in the other room. And our goal, and I think one thing we want to pass on to everybody and our staff and everybody, is that we actually try and provide compassionate care to everybody, and regardless of the situation. And frankly, as emerge docs and our nurses, we really love it when we have a chance to connect with our patients and sit down and talk to them. Sometimes it's too busy to do that, but if we do have a chance, we try our best. This is an example of one of our recess rooms. And in our new hospital, our new emergency department, hopefully we'll have bigger rooms, and I'm not sure that we can actually reconfigure things that way. But that does give you an example of an ongoing resuscitation, and we've sort of been aware of patient confidentiality, so you can't really see the patient, but that is a real live patient getting a chest tube put in by our team in one of our trauma rooms. And I think that is the challenge, is that we leave that room and then we have to talk to somebody who may be not super happy that they've had to wait. And we do our best to try and give excellent, compassionate care always. And I think that's our goal moving forward, is to try and meet the targets that we have. I think we've done a pretty good job in the last year or so in terms of doing that, but I think it's still something we're working on, and we do appreciate all the input that we get. Who are emergency doctors? This is actually a picture of most of our staff, and I don't know if anybody remembered on Carol's talk did anybody recognize Dr. Gene Dagnoni there? So Gene was actually my chief, and in fact in that picture he looked a bit like Elvis Presley, I have to say. And he's not in this picture, but his son is actually one of our emerge docs, and you can see a group of them up there. And in fact, I think I was many of their residency directors in the last 19 years, which says that I'm getting pretty old. But we have a really good dynamic group of emerge docs. And I don't want to give them all the limelight because they work with the help of all of our great nursing staff and physiotherapy and everybody else. But I do think that compared to most medical groups, I think we are probably the best cyclists and the best triathletes and that sort of thing of anybody, perhaps hockey players, but that's just the way it is in emergency medicine. What does it take to be an emerge doctor? You do your 4 years in med school and 5 years of a residency program. And there's Gord Jones, who's our department chairman. He's had 30 years of experience as well. So I think sometimes the combination of the young versus the old is actually really good, because we feed off the enthusiasm of our young staff who've got lots of energy, and some of the older dogs are kind of like, I don't think we should do that, and there's usually a compromise. I might have inflated our KGH numbers, but it seems like they're rising all the time, and on a busy day we see about 175 patients per day and about 130 at the Hotel Dieu Hospital. Significant amount. The interesting thing is these numbers continue to rise, and that's part of our challenge, is that the needs and the numbers go up every year. And so over the last couple of years they've gone up about 17%, so we are trying to cope with that. So we see about 100,000 patients per year between the two centers, which I think is a pretty significant amount. And basically the emergency department is the entryway to healthcare in terms of the hospital in Kingston. And we'd like there to be other alternate routes as well, through family docs and through the clinics and that sort of thing. But the reality is a lot of this still happens via the emergency department. And one final note, about 1 to 2% of our patients are life-threatening. In other words, cardiac arrest, major trauma, will die within seconds or 10 minutes or so without proper care. So every day we get maybe 1 or 2 people like that. About 10 out of every 100 patients that we see have significant problems, i.e., ruptured appendix, heart attack, myocardial infarction, stroke, that kind of thing. And probably another, say, 50 out of those have serious issues like appendicitis and that sort of thing. And then at KGH, there's probably another 20 or 30% that have minor problems. And one of the common misconceptions that many of our patients and their families have is that the emergency department is clogged up at KGH because there's people with runny noses, and that's not really the case. The biggest, those are actually fairly easily seen and quickly dealt with, and sometimes they might have a little bit of a wait, but they're not the biggest challenge. The big challenges are patients that need to be admitted, finding rooms for them, and the hospital's actually making a pretty good run at doing that. So in our apartment, we deploy about 7 people at KGH per day and 3 at the Hotel Do. We have people on call. I will actually be going there at 2:30. So we actually do a lot of shift work. And it just shows you that small group there covers quite a lot of shifts and that sort of thing. But it's a privilege. We love it. It's our jobs, and we actually think it's really quite fun and challenging. And I think most of us stay here because we love Kingston and love our hospitals. So.
I just want to talk a little bit about our staff in terms of our physicians, because we all do the shift work and we do the nitty-gritty and emerge, but we all do things outside of our shifts as well. And it's like any job anywhere, it's only as good as the people that you have, really. So this is Dr. Heather Murray, one of our colleagues, who just got an award, the Queen's Principals Award for education and teaching, and she redeveloped a lot of the curriculum for our medical school. We teach all kinds of residents in the hospital, not just emergency residents, because learners from all different services come through the emergency department, from pediatrics to OB-GYN to orthopedics to gen surgery. It goes on and on. So. A lot of our teaching now is done in a high fidelity simulation lab, which is new in the last 5 to 10 years. And we really at Queen's lead the way in this type of education. Terry and I have been the program directors for the residency program. So we sit at the national tables where we talk about education and teaching, and we're far and away ahead of other centers in terms of this kind of teaching. And so it comes a bit from things like the airline industry, where it's very important that pilots learn how to deal with emergency situations through simulation. And it's the same thing in emergency medicine and critical care. Our residents need to learn those skills under stress in an artificial environment. So that's a mannequin they're working on, and we're in the background changing vital signs, and it's kind of fun to teach that way because you never know where the scenario is going to go. So it's pretty fun, actually. In the last 10 years, we've trained probably about 150 emergency physicians, and they're across Canada, coast to coast now in different centers. And in fact, they've gone to different parts of the world. Our physicians have gone to Everest and Antarctica and have been involved with NASA in the past. Emergency work is amenable to many other jobs that you can do, including humanitarian efforts. It's a skill set that we can take to do other things as well. Our department's actually well known for research, and we have top researchers that are well recognized. And this is one of the common things that's used across the world that one of our staff helped develop, was just basically decision rules about when someone bangs their head, who are the ones that really need a CAT scan, that kind of thing. This is Marco Civilotti. He's one of our top researchers, and he's also cross-certified as a toxicologist, so he's very handy for us when weird overdoses come in. So right now he's looking at patients that come in with a mini stroke, who's at risk for a full-blown stroke in the coming weeks or months, because we really need to focus on that group. And this is Dr. Daniel Boone, and her research is into education, and so her project right now is looking at how we give feedback to junior residents. This is Joey Newbery. He's one of our ultrasound experts on staff, And Joey's looking into research to treat hip pain when people have broken their hips. So rather than giving them intravenous morphine, he uses ultrasound to localize and give a local injection to deal with the pain. Sorry, the mic's going a bit crazy on me. This is Adam. He's one of our new hires here. And Adam's doing very cool research on, he's trying to find out markers of an expert physician in resuscitation scenarios versus a junior physician, and what are some of the differences that you can see. And he's looking at eye pupil diameter physiological responses, and they're very different between someone who's used to running a resuscitation versus someone who's new at it. This is Steve Brooks, and sometimes the research turns into innovation, and Steve's a great example of that. So he has developed an app. I'll back up a bit. We've discovered in cardiac arrest that CPR is more important than we ever thought. If you can get quick CPR there, we can save lives, you know. And what happens a lot of times, you have a cardiac arrest, 911 is called, and CPR isn't done until the paramedics get there 10 minutes later. But there's someone right next door who knows CPR, they just don't know that the person's down. And so people who know CPR can have this app on their phone where when 911 makes the call, they're notified that CPR is required nearby. It's a great innovation. It's throughout North America now, but Kingston's one of the few Canadian spots actually to have it in place right now. It's in San Francisco, New York. It's all through the US, but it's because Steve is here that we've started that innovation in town. So it's definitely going to save lives. I'll just give you a little example of an advertisement about it. Sorry about the sound. You'll get the idea though. So that's just a sampling of it. And if you happen to know CPR, you can download that app. It's called Pulse Point. We also have people who have a global perspective in our department, and Dr. Sue Bartel is one of those people. So her research interest is looking into how best to deploy humanitarian efforts in war-torn regions or regions with natural disasters. So she travels the globe researching that sort of thing. So we're a pretty diverse group, and like I said, we all do things outside of our shifts in the emergency department. We had an external reviewer come in December just past to look at our department, and one of his comments was that we acted like a family, that we're very close-knit. When you think about it, in Kingston, there's no other center in Canada that has a tertiary care level hospital and a medical school associated in such a small community. So, and I think that flavor comes through in our department, and our residents were a very sought after program, and I think it's because we really have that kind of family feel, and he pointed that out in his review, and it's the way we see our department and our residents and ourselves, our nurses, we very much feel like a team in what we do. We do have challenges, there's no question. Anyone who's been in the emergency department in the last few years would know that we're challenged. And it's the same way across North America. And some of the frustration in a way for us is that it's seen as an emergency department problem. It is our problem, but the solutions lie outside of our department. And we have admitted patients that just can't get a hospital bed, and so they're held in the emergency department, and which blocks our stretchers, which blocks our waiting room. And so we've done all kinds of things that Julie outlined to try to help alleviate that problem, but the solutions, the ultimate solutions, lie outside of our departments, unfortunately. For now, though, we're looking at hopefully some small renovations that we can do at both of our sites in order to just serve patients better and get them through quicker. And these are relatively minor renovations. We hope to have a new department, but we know that that's not going to happen for quite a long time. So, but if we can make a few changes, we think that we can really be more efficient with those changes. And we've actually got preliminary plans for what we're hoping to do. We have to think outside the box because right now we're stuck with what we have. All emergency departments are having to think differently, I think. And a new concept of what if you don't have to wait in the waiting room? That's a new concept that we're looking at. Not sure that we'll get there. But what if we could just bring patients in immediately, see the doctor quickly, get the test front-loaded instead of waiting and then having your test done and now waiting to see the doctor. You know, it's all a very long process, and I think there's great improvements that we could make. We always need equipment. Actually, looking at this slide reminds me of an email I just got this morning. We need a cabinet. We just haven't had the money to get a proper storage cabinet, which sounds funny, but the email I got this morning is we have a little light that we use for many different things, and it's always going walking along with a few other pieces of reasonably expensive equipment. If we could just have a locked cabinet and inventory what goes out, it would help us a lot, but there's all kinds of equipment we could make good use of. So this is Louise Rang, and through the foundation a couple of years ago we had this ultrasound machine donated, and I believe it's about a $30,000 piece of equipment. And we have this same machine at both sites. We use it every day, all day, and in fact we can say for certain that it's actually saved lives, that we can diagnose things that we would have had to send people down to the radiology department for, that we can diagnose on the spot. And so it helps us every single day. And we've been eternally grateful for that piece of equipment. We make good use of it. And in fact, we brought the machine to demonstrate. Don't worry, we have a little handheld one, so they've still got one in the department. But we just wanted to show you our bell and whistle that we're very proud of that was donated. And my son's in the back there. I got him to be our guinea pig today, so he's going to be our ultrasound, personal ultrasound. So we invite you to just meet us in the hall if you want, and we'll show you a few things that we do with it. So, and I want to thank you very much for this opportunity. We really appreciate being able to come and let you know what we do. So, thank you.